If you don't want your options for treating perimenopausal symptoms and decreasing your risk for the chronic diseases of aging to be limited without so much as an informed discussion because you're at an increased risk for blood clots, or you've been worried about blood clots as a possible side effect of hormone replacement therapy, today's episode is for you. You're going to know more than most doctors about the details of this by the end of this episode. You're listening to the Health Courage Collective podcast, episode 250. Can I take estrogen if I've had a blood clot? There's an exclusive group of high-performing women who thrive through perimenopause and beyond and successfully prevent or drastically delay all of the common diseases of aging so they're capable of living and giving more as they get older rather than less. The Health Courage Collective podcast is for you if you're ready to become one of them. I'm so happy you're here. Hello, and welcome to another episode. I hope you've had a lovely week this week. How are your injuries and chronic pain? Did you prevent them all in 1 week? It doesn't work that way, but it's incredibly powerful to know that a big portion of injuries and chronic pain can be prevented by proactively evaluating our movement patterns and body alignment. We're going to talk about looking for ways to optimize our strength in our weak areas and our mobility in our tight areas as a way to stay active and strong even into old age in an upcoming week. Today's episode is going to be a little bit longer than usual. I thought about splitting it up into 2 weeks, but then I was like, no, let's just do it all at once. Okay, so here's something I hear all the time. A woman has questions about relieving symptoms of menopause, like hot flashes that interrupt her sleep, or brain fog, or decreased libido, or all of the above. And we'll talk about the options, and she'll say, oh, no, I can't take estrogen because I've had a blood clot once. Or my mom got a blood clot when she took estrogen. Or my sister had a blood clot once. Or I really want to take estrogen because I'm profoundly feeling the effects of its withdrawal, and I know the long-term risks of going without it, like osteoporosis, cardiovascular disease, and Alzheimer's disease, but my doctor won't prescribe it to me because I had a blood clot once, or because my mom did, or my sister. It's the second most common reason why women and their doctors incorrectly believe that they are ineligible for hormone replacement therapy. It's really easy to end the discussion about the benefits of hormones as soon as the word blood clot is mentioned, but the easy way out is almost never the best option, so let's talk about it. Blood clots are serious, and you never want to be blasé about increasing your risk of getting one. I have always been fascinated by the clotting cascade. It's pretty freaking brilliant. We could talk about it for hours, which we're not going to do, but let's just go over the bare bones basics because I think it'll deepen your understanding of how all of this works together with estrogen. I'm excited. So, if we get some kind of cut or abrasion or contusion, as we are wont to do as clumsy humans stumbling around in the world, we need a way to not lose all of our blood in our body. Lucky for us, we have one, a pretty fantastic one with backups of the backup plans, so we can be sure to stay alive even if we snag a hangnail or get tossed into something sharp while driving our demolition derby car. There are 4 stages to stopping bleeding called hemostasis. First, when a blood vessel, no matter how tiny, is injured, the endothelial cells there release vasoconstrictors to contract that smooth muscle, shrinking the diameter of the vessel and limiting the amount of blood that can flow. Next up is platelet activation with platelet activating factors. Platelets are cells in your blood that can come on site and suddenly become stickier by shooting fibrils out of their cytoskeletons so that they can stick to damaged blood vessel lining cells and collagen at the site of the injury to start forming a little plug, like something from a sci-fi movie. While this is happening, a series of enzymatic reactions, mostly with substances formed in the liver, send out coagulation factors in the blood. There are so many coagulation factors, like at least 30, I think. They all 30 work together to weave this web of different types of fibrin that's all cross-linked at different angles. So it's a stable and reliable stopper of blood flow that helps you to not bleed out as your other amazing cells and cell-signaling molecules go to work building you some new blood vessels and skin and whatever else you need to get back to your demolition derbying. And if that's not cool enough for you, pretty soon after your stable clot is formed to save your life, the platelets that are part of the clot retract their fibrils back into their cytoskeletons, shrinking the volume of the clot, and tissue plasminogen activators Activate substances that start safely dissolving the clot slowly so it's gone at just the right time when blood vessels have been restored so that blood can start flowing appropriately again. Pretty cool, right? For most people, it works wonderfully. I think the main thing to remember is that there are different parts of clot formation. Platelets are separate from the coagulation factors, and there are a lot of different coagulation factors, many of which are produced in the liver. Got it? Okay. Some people have blood clotting problems where their blood doesn't clot enough, which can be catastrophic, like hemophilia. And some people have blood clotting problems where their blood clots too easily, which can be catastrophic, like a stroke, heart attack, or pulmonary embolism. You'd be more likely to get a problematic clot if you had too many platelets or too many liver-produced clotting factors. Not having enough clot-dissolving enzymes could also be a problem. There are blood tests that you can get to check for blood clots or clotting problems. A D-dimer test reveals that your body is actively breaking down a blood clot right now. A PTINR or PTT test measures how quickly your blood clots. We use this all the time in the pharmacy world, or I guess we used to use it all the time in the pharmacy world, and now we only use it sometimes to adjust patients' Coumadin doses. That's an anticoagulant medication. There are genetic tests that can test for genes known to cause clotting disorders like factor V Leiden and systemic lupus erythematosus. And there are tests that can test for specific collagen factor proteins in your blood, the ones that are mostly made in the liver. Some reasons your coagulation factors may not be at normal levels could be liver disease, vitamin K deficiency, cancer, immune system disorders, genetic disorders, autoimmune disorders like lupus, and having blood transfusions. Before we get around to what all of this has to do with estrogen, we need to remember that there are multiple kinds of estrogen. Your body makes multiple types of estrogen, and Big Pharma makes multiple types of estrogen, only one of which overlaps. Is overlaps the right word? Yeah, like a Venn diagram. One commercially available prescription ingredient is the same kind of estrogen your body makes. The most potent and most useful one, fortunately, estradiol. Compounding pharmacies can match 3 types of estrogen that your body makes. But there are other types of drug products with non-human identical estrogen. The 2 main synthetic ones are conjugated equine estrogen or Premarin, which is a conglomeration of horse estrogens extracted from horse urine. The other is ethinyl estradiol, far and away the most common estrogen in birth control pills. There are a few new synthetic estrogens starting to be used in newer birth control, but those are the main 2. They're both taken orally as a pill. Studies are clear that taking either of those 2 prescriptions increases your risk of getting a blood clot. It's basically an established fact. And getting older increases your risk of getting a blood clot, as do being immobile, especially after surgery, smoking, and being overweight. There are also oral estradiol pills, the human identical estrogen swallowed as a tablet. These do seem to also increase your risk of getting a blood clot. Probably not as much as those other 2 synthetic ones, but that's my own and probably biased opinion. And we don't have as many studies about oral estradiol and blood clotting risk as we do about the other 2. Another factor to consider is that you should be taking progesterone if you're taking estrogen, even if you don't have a uterus anymore. And many of the studies on the conjugated equine estrogen had a synthetic progestin called medroxyprogesterone acetate mixed in with the horse estrogen. And all birth control pills contain a synthetic progestin of some variety. Lots of different kinds of synthetic progestins in birth control. And we're going to talk about one study later that used human identical estradiol, but a synthetic progestin with it. So then it's hard to tease apart. Did the clot come from the estradiol or from the synthetic progestin? Women who take oral synthetic estrogen with an oral synthetic progestin are 2 to 4 times more likely to develop a blood clot than women who don't. The risk is highest for the first 6 to 12 months after starting taking the pills. Then it goes down over time. Therefore, it's become pretty standard practice to believe that all estrogen increases your risk of getting a blood clot. Ergo, it's in women's best interest to not give estrogen to anyone who has ever had a blood clot before or who believes she has an increased risk of clotting. Maybe her mom or sister had a blood clot. And to be fair, some women do know for sure that they are at an increased risk for blood clots, and that matters. But practitioners think that their, quote, abundance of caution is in their patient's best interest. Why take the risk? Just tell her estrogen isn't an option for her. Plus, it will lower their own risk of getting sued when she someday throws a clot. It's understandable, right? You can kind of see where they're coming from. A good provider is overly cautious. Why prescribe a totally optional thing if she can successfully languish along without it? So there's the question. How would you answer it? I want you to come up with your own opinion. My argument here is that estrogen isn't an optional add-on like guacamole. Take it or leave it, your life will end up exactly the same in the long run. Yes, there are risks to taking estrogen that should be carefully considered by every woman who has ever worried about blood clots. But there are also risks to not taking it, and they are almost never considered or disclosed. What if going without guacamole would drastically change your experience of life 30 years from now? Whatever you choose for yourself is completely fine with me, so long as you have all of the information you deserve to have to make an informed choice, including the risks of living with extremely low estrogen levels for decades and of having the majority of the tiny amounts of estrogen you do make to be in the form of estrone. Not to mention going without progesterone and testosterone, which is a topic for another day. I'm sure you're pretty familiar with the commonly mentioned menopausal symptoms. Hot flashes, night sweats, trouble sleeping, brain fog, moodiness, vaginal dryness, low libido. No one will be surprised that those can be helped with hormone replacement therapy. But the list of other ways replacing your estrogen and or progesterone and testosterone will help you is too long for me to even list. Less joint pain, more focus, more energy, improved ability to add strength and muscle mass, way lower risk of osteoporosis, improved metabolic health, meaning more insulin sensitivity and ability to regulate your blood sugar. This alone decreases your risk of all of the chronic diseases of aging, all of them. A lower risk of the majorly sexist disease, Alzheimer's, and lower risk of cardiovascular disease like heart attacks and strokes if you start taking it within 10 years of menopause. Not to mention improved athletic performance, younger looking skin, healthier hair, a slowed loss of fat pads in the face. I'm sure I'll think of a ton more after I stop talking. Oh, hugely decreased risk of urinary tract infections when taking vaginally, along with improved vaginal moisture, decreased pain with sex, improved libido, and lower risk of urinary incontinence. We talked about those in episode 213. The list goes on and on. I just want you to know that living with extremely low levels of estrogen puts you at majorly increased risk for frailty, osteoporosis, Alzheimer's, cardiovascular disease, and feeling like crap, or a bit crazy. I also think you're at increased risk of prediabetes, chronic pain, and cancer, especially breast cancer, if you live for a long time with estrone being your main form of estrogen, which happens after menopause. We don't have definitive studies to prove that this is the case, but the evidence does suggest that probabilities do shift depending on what type of estrogen is most commonly found in your body and which estrogen receptors are turned on and turned off. We talked about estrogen receptors in episode 162, Understanding Estrogen Receptors. They matter. So we know the risks of living without estradiol. The list is really long. And we know that taking horse estrogen as an oral pill, taking the synthetic estrogen in birth control as an oral pill, taking synthetic progestins of all kinds, and taking human identical estradiol as an oral pill increase our risk of developing blood clots. This is the end of the discussion for so many women with a perceived or real increased blood clot risk. But oral estrogens aren't the only option. They're not even a very good option, even if you aren't at increased risk for blood clots, in my opinion. We talked all about this in episode 236, How to Take Your Estrogen, Oral versus Topical. If you remember in that episode, we talked about how everything you swallow, including estrogen tablets, goes through what's called first-pass metabolism in your liver. Basically, your liver is on 24/7 surveillance of everything that you ingest, and it metabolizes a lot of it to slightly different molecules. It's a fabulous way to make sure we don't die of poisoning. The people who believe oral estradiol tablets are the best take them because they see that the estrogen metabolites created in the liver offer more cardiovascular protection than regular estradiol made in your ovaries that travels around your bloodstream. I think not sending estradiol through first-pass metabolism in your liver by bypassing your liver completely and getting it into your bloodstream through your skin is more of a mimic of how your body is used to receiving and using estradiol. Okay, blood clots are serious and you don't want to be reckless or stupid about something that could be fatal. But I don't think the right answer is to not even consider hormone replacement therapy. So let's consider it. There is nuance needed, and what you and your doctor decide together should be the right answer just for you and you alone. Human estrogen supports the health of blood vessels by encouraging the production of prostacyclin and also nitric oxide, which we talked about way back in episode 9, nitric oxide and the power of NO, which helps blood vessels be healthy and able to relax and dilate. There are estrogen receptors on the cells lining the inside of your blood vessels, your endothelium, which we talked about in episode 178. Having a healthy endothelium drastically drops your risk of cardiovascular diseases, and estrogen there promotes healthy vascular repair and suppresses the formation of atherosclerosis. Estrogen also promotes arterial elasticity, making it easier for your arteries to stretch and retract as needed. These benefits all go away as we lose estrogen. And if you're essentially without estrogen for about 10 years, adding estrogen back won't resurrect them, which is why some people often talk about there being a so-called window of opportunity to start hormone replacement therapy. It's not totally true because there are different things that estrogen helps with. But as far as cardiovascular disease, if it's been more than 10 years since menopause, you've lost the cardiovascular protection of estrogen and you're not going to get it back. But what about blood clots? There's a genetic blood clotting disorder called factor V Leiden. People with this genetic condition are 4 times more likely to get a blood clot than people without it. And women with factor V Leiden who took oral conjugated equine estrogen proved to be 25 times more likely to get a blood clot. Not good. Way not good. But women with factor V Leiden who took topical estradiol were proved to be 4 times more likely to get a blood clot. Exactly the same as the women who didn't take the estrogen. Pretty interesting. In the book, The Great Menopause Myth, the authors talk about this study and say that women with factor V Leiden who were able to successfully bring a pregnancy to term actually had a decreased risk of clotting while on human identical topical estradiol hormone replacement. In a February 2025 article in the journal Research and Practice in Thrombosis and Hemostasis, the thrombosis experts who wrote the article explained that estrogen is prothrombotic, meaning likely to cause blood clots, through several mechanisms. It's important to note that these were studied in women on oral synthetic ethinyl estradiol, the stuff in birth control. Estrogen elevates von Willebrand factor levels, increasing platelet adhesion. It increases thrombin generation and increases clotting factors 7, 8, 10, and 13, and fibrinogen and activated protein C. Estrogen also decreases plasma levels of natural clot inhibitors, antithrombin, protein S, and tissue factor pathway inhibitor. Okay, so von Willebrand factor is mostly made in the endothelium, that lining of your blood vessels, and the bone marrow. And that's the thing that activates your platelets to get sticky. Tissue factor pathway inhibitor is mostly made in the endothelium, but a little bit in the liver. But all of that other stuff, the clotting factors, 7, 8, 10, 13, fibrinogen, activated protein C, protein S, and antithrombin, is all mainly produced in the liver. That's a big deal. How come? Yeah, you're so smart. As explained by Bryony Cutts and Christy Fennessy, thrombosis authors, almost all of these prothrombotic effects of estrogen increasing the likelihood of a clot, most likely come from the first pass metabolism of oral estrogen in the liver, not from estradiol itself. Here's a direct quote from their article. Many patients, especially those with a past history, family history, or risk factors for VTE, that means venous thromboembolism or a blood clot in the vein, cardiovascular and cerebrovascular disease, are often denied access to HRT due to concerns that the risk outweighs the benefit. Transdermal estrogen is absorbed through the skin, directly enters the bloodstream, and avoids the reduced bioavailability that occurs with oral estrogen. This means transdermal estrogen avoids the first pass hepatic, that's liver, metabolism, which reduces estrogen exposure to clotting factors within the liver. It is postulated that this is the mechanism that makes transdermal estrogen less thrombotic, end quote. They go on to describe how oral estrogen does increase the risk of a blood clot in a vein, especially during the first 12 months after starting it, but that in a 2018 study of 26,471 cases of blood clots, using a transdermal estradiol had a relative risk of 0.97, and using a transdermal estradiol plus human identical micronized progesterone had a relative risk of 0.93 with a 95% confidence interval, meaning the risk for blood clot was 3% less for topical estradiol users than non-hormone replacement users, and 7% less for topical estradiol plus natural progesterone users than non-hormone replacement users. Those numbers are pretty small, like a 3% decreased risk, so it's not statistically significant that it decreases your risk, but it does prove that it does not increase your risk. A different study in 2019 showed that topical estradiol does not increase incidences of blood clots, but conjugated equine oral estrogen and synthetic medroxyprogesterone acetate do. And a 2020 study found that topical estradiol does not increase risk of stroke. A 2022 study in the Journal of Post-Reproductive Health says that oral contraceptives and oral hormone replacement therapy pills have been shown to induce an acquired resistance to activated protein C, and that oral hormone replacement therapy increases the amount and speed of activation of thrombin generators, so those clot-forming substances, but that transdermal hormone replacement therapy users had the same thrombin-generating time and amount as non-users. The author, Guy Morris, also points out that estrone levels are much higher in women taking oral estrogen, and that estrone is a potent inducer of liver protein synthesis. The estrone levels correlated with the increased thrombin production. Super interesting. I have all of his references to all of these different studies if you're interested. A study in France showed increased risk of blood clots with oral hormone replacement, but not topical. The Million Women study in the UK showed the exact same thing. Studies of studies called meta-analyses show that the risk of blood clots in women on topical estradiol is the same as women who don't take hormone replacement. Guy Morris also points out that it's clear that the type of progestin matters a lot. The synthetic progestins in birth control, and especially the synthetic progestin medroxyprogesterone acetate, are prothrombotic, meaning they increase the risk of clots all by themselves. But human identical progesterone, which you can take safely orally, unlike estrogen, does not increase risk of clots. There have been lots of studies showing that transdermal estradiol does not increase blood clot risk in regular women, but what about women with known increased risk for clotting? Not nearly as many studies, but there was that one that I mentioned in the women with factor V Leiden, no increased risk above their already increased risk. One study in 2008 reported no increased risk of clot above baseline, which is the already increased risk in women with factor V Leiden and prothrombin gene G20210. The women with genetic increased risk who used topical estradiol had the exact same risk as women with their same genetic mutation who didn't use estrogen at all. The recommendation of the authors of the thrombotic study is that if patients and clinicians wish to use hormone replacement therapy, transdermal estrogen can be safely used as first-line therapy. The American Society of Hematology has published guidelines saying that patients get tested for thrombophilias before starting hormone replacement therapy if the patient has a family history of blood clots in veins, plus intermediate or high-risk thrombophilia is present in the family, such as known protein C, protein S, or antithrombin deficiency. They say it's not necessary to test for factor V Leiden prothrombin gene mutation heterozygosity, which might have been done in the past. This would be if you have only one copy of the blood clot disorder gene. They say that's a non-issue. You can safely take hormone replacement therapy the same as anyone else. But if you have two copies of the gene, you need to be more cautious. The most common thrombophilias are those factor V Leiden and prothrombin 20210. Next up are protein S deficiency, protein C deficiency, and antithrombin deficiency. A quote from Guy Morris's journal article says, "Although there is no robust randomized controlled trial evidence available for the risk of venous clot comparing the route of HRT administration in specific populations, such as women with diagnosed thrombophilia, there is high-quality, large-scale epidemiological evidence which demonstrates that transdermal HRT with micronized progesterone does not seem to be associated with an increased risk of venous blood clots in such women. The use of progesterone with transdermal estrogen does not seem to increase the risk of clot, although this analysis was based on low numbers of women." End quote. So the only randomized controlled trial on women with a personal history of blood clots, but not necessarily a diagnosed thrombophilia, was stopped early due to increased risk of blood clots. It was called the EVTET, EVTET study, and it used 2 milligrams of oral human identical estradiol plus 1 milligram of oral synthetic progestin norethistrone acetate compared to placebo. So there we go with that synthetic progestin again. And the oral hormone women got more blood clots. A different study that wasn't a randomized controlled trial, but was a cohort study on women with a personal previous blood clot. The study was called MEVE, M-E-V-E, which stands for menopause, estrogen, and veins, if you care, showed increased risk of clot recurrence with oral estrogen plus progestin, HRT, but no increased risk of blood clot recurrence with transdermal estradiol. These two trials don't give us a ton of data specific to women who have personally had a blood clot before, but they do teach us that taking 2 milligrams of human identical estradiol as a pill, along with 1 milligram of this synthetic progestin norethistrone acetate, will increase your risk of getting a blood clot again, and that topical estradiol does not seem like it will, which is the exact same thing we'd expect to see in women without a previous blood clot, or women with genetic predisposition to clots. They all come up with the same answers. The British Menopause Society recommends that, quote, "in the presence of known risk factors for blood clots, including personal history of venous clots or family history of blood clots, the combination of transdermal estrogen and micronized progesterone offers a safer option that is unlikely to increase blood clot risk above the individual's intrinsic risk. Discussion with a hematologist should be considered in postmenopausal women at particularly high risk for blood clots who are being assessed for HRT." End quote. This was a lot. It was a long one. Good for you for sticking with it when you could have been listening to a podcast about true crime or fermenting your own kefir soda or whatever. What is your takeaway? I hope you found it useful in making a decision for yourself. The key points I'd like you to remember are: oral estrogen, whether human identical or synthetic, increases your risk of blood clots because the metabolites generated during first pass metabolism in your liver alter the clotting factors that are part of the clotting cascade. The type of progestin you take with your estrogen matters a lot. Only human identical micronized progesterone has been shown to not increase the risk of blood clots, and you can take it orally. The increased risks to women with predispositions to blood clots, either because they've had one before or because they have a genetic mutation that increases their risk, seem to match with the increased risks in women without these conditions, namely that oral estrogen and synthetic progestins will increase their risk even higher, but topical estrogen and human identical progesterone do not. I think it's also useful to think through what caused your blood clot in the past. We already talked about genetic predispositions. You could work with your hematologist about that. You might even want to go on an anticoagulant drug along with your hormones rather than foregoing the benefit of hormones altogether. If you have no idea why you got a clot in the past, you and your provider might decide to test you for a genetic condition and go from there. Criteria for thrombophilia testing, as described in the British Journal of Hematology, suggests that testing for a heritable thrombophilia is only indicated if a first-degree relative with venous thrombosis has been tested and the result is positive, only in that it may aid counseling of a high-risk variant. At that point, the prescriber should offer the woman transdermal HRT before offering testing, as a negative thrombophilia screen result does not exclude an increased risk of venous thrombosis. That's kind of a mouthful, but they're just saying if you think she's at increased risk, you can test her under these certain conditions, but always offer transdermal estrogen first. The British Menopause Society advises that testing for thrombophilia may be justified in limited circumstances, such as women with a strong family history of clots, meaning multiple first-degree relatives affected by clots in veins under the age of 50, recurrent blood clots, or a positive family history of a specific thrombophilia. Women with a personal history of a blood clot within the last 12 months who are 50 years old or older should be screened for an underlying medical cause such as cancer, as well as thrombophilia. If your blood clot was recent, you should dig into what could have caused it and wait to figure that out before trying to jump on hormone replacement therapy. If you had a blood clot while pregnant with no other possible cause you can think of, you might not want to take any type of hormone replacement therapy because pregnancy is a state of high amounts of natural hormones running around your body. Well-done hormone replacement therapy would never push your levels that high, but the fact that hormones that your body produced on its own made you get a blood clot is a big red flag. If you got a blood clot after surgery or an injury that kept you immobile, I think you'd be safe to start transdermal estradiol plus micronized progesterone as long as you keep in mind the signs and symptoms of blood clots and the things that will increase your chance of getting one again, meaning surgery, immobility, smoking, getting older, gaining weight. If you have a long trip, wear compression socks. If you have to have surgery, your doctor might want to prescribe you an anticoagulant plus or minus compression socks, and make sure that you move regularly every day. If you or a family member got a blood clot while on birth control pills or oral hormone replacement therapy, some guidelines say you should not be put on hormone replacement therapy, but I think that makes no sense. We know that oral estrogen and synthetic progestins are prothrombotic and increase clotting risk, and transdermal estradiol and micronized progesterone do not. So that's like denying you proper care because when you went on Coumadin, you bled more easily. Coumadin is an antithrombotic. Of course, people who take it bleed more easily. That's what it does. If you don't want to bleed more easily, you don't take it. Take something that doesn't do that instead. We have very good evidence that the topical estradiol and micronized progesterone do not increase clotting risk, but the others do. Also, I haven't even mentioned vaginal estrogen. Go back and listen to episode 213 if you want to know more about vaginal estrogen. It's 100% proven to not increase your risk for blood clots, and anyone who says it does is an idiot. Unless you're talking about vaginal birth control, because that does still seem to increase clotting risk, even though it's not taken orally, because that ethinyl estradiol is such a potent clot inducer. If you've had a blood clot before and it's making this decision hard for you, I feel for you. It's a lot to think about, and it makes finding a provider willing to even stop and consider hormone therapy as a valid and safe option for you very difficult. And it's not something you should take lightly. I think there are some women who should not use hormone replacement therapy because of concern for blood clots, but that they're very few and far between. That the overabundance of caution we're told is done out of concern for women's well-being is harming women. Hormones are not a side of guacamole. Nice to have now if you're specifically offered the option, but won't change your experience in the future. What you choose to do with your hormones now will absolutely affect the number of years lived in good health in your future. Whether that's choosing to replace them as they decline so that your cells have the tools to keep operating with more power, or knowing exactly all of the things you need to manage to be able to live well without them. And remember, not choosing is also a choice. If you're still not sure which approach you want to take, how a world-class hormone replacement regimen is even put together, or how to find a knowledgeable and collaborative provider to work with, get on the waiting list for my new program, Hormone Peace of Mind, by clicking the link in the show notes or go to my website, www.healthcouragecollective.com. I'd love to have you help me create a helpful framework that all kinds of different women can follow to get the most effective and most enjoyable personal results possible. Elite level care shouldn't be a secret that only rich and famous women have access to. So let's change that. As always, thank you so much for being here today. This was a long one. You are fabulous. Next week, we're going to talk about what might be the coolest part of your body, your anterior mid-cingulate cortex, and how to increase it to grow your willpower, control, grit, and tenacity so you have the gumption to get whatever you want out of life. Until then, understand the differences between oral and transdermal estrogen, and don't be normal. Pat yourself on the back for sticking with it till the end of this episode. I know your attention is valuable and I don't take it lightly. I'm so grateful that you care about not settling for anything less than world-class care and results. Strong women who feel good change the future. I'd appreciate it so much if you'd share this podcast with a friend so we can make elite-level perimenopausal outcomes the rule rather than the exception. This podcast is for entertainment and information purposes only. Statements and views on this podcast are not medical advice. This podcast, including Christina Hackett and producers, disclaim responsibility for any possible adverse events caused by use of information contained herein. If you think you have a medical problem, consult a licensed physician.